Good morning to you all, and welcome to the fifth lecture of the 2020 Palliative Care Lecture Series. Hospice NZ would like to thank and acknowledge Cancer Research Trust New Zealand for their generous support and funding to deliver these free lectures. The lecture today will be recorded, and it will be available on the Hospice New Zealand website. Please be aware there will be an opportunity for questions at the end of the presentation. We would now like to introduce our guest speaker today, Fiona Hewerdine. Fiona works in the Bay of Plenty District Health Board in the community and also at the local hospice. The topic today is looking at the work and role of a speech and language therapist in palliation. Fiona, please go ahead.
Kia ora, good morning. Quality living and dying, what can your speech therapist offer? This talk was not created in the fires of Moria, but in the bubbles of COVID. So I hope you enjoy the backdrop to my slides. Ko Waio, who am I? Ko Lincolnshire Wool, Te Manga, ko North Sea Te Moana, ko Singapore Airlines Te Waka, ko St Wilfrid's Toku Marae, ko Clan Macrae, Toku Iwi, ko Hewerdine, Toku Hapu, Toku Ingoa, Fiona. I came to New Zealand 21 years ago and had a passion for terminal and palliative diseases. But as a speech and language therapist, I was very isolated. Palliative care was just becoming a specialty here, and I didn't really have a peer group. I was like the takahi on your slides, very isolated on my own. So I sought further study and joined the Goodfellow unit in Auckland, and went on to meet my herd, a whole multidisciplinary team of people who spoke the same song or spoke the same language. A big shout out to New Zealand, because now there are lots of people who have palliative speech and language therapists at their fingertips across the country. So I'm no longer an isolated takahi. We have been multiplying. So my hope for the talk today is that I will share a little bit about our work, but also really a big shout out to the speeches in your area. So I hope you take the opportunity to find out who they are, possibly in your room, and meet up. Home palliative care should be recognised as an exercise in prevention of ultimate suffering through prioritising the diagnosis and skillful management of sources of distress in the form of physical symptoms, psychosocial and spiritual concerns. Speeches have a great opportunity to play a role in the lives of those who are on a shorter piece of string. So my outline for today is to cover these 7 areas that will face all your palliative patients during their journey or end of life. And I hope that we will be able to illustrate how your therapist may be able to minimize the impact of these challenges, and we'll look at each one separately. So to try and help you visualize the sort of cases or people that the speech therapist might see, I've divided them into 3 sections. Degenerative neurological disease, you can see a column of variety that you'll be familiar with there. The big C, where they're not head and neck specific, so the impact of thyroid might mean that the patient ends up with a tracheostomy, and we're there because we manage trachees and we can help with speaking valves. It might be a brain tumour, so the patient becomes aphasia, comprehension challenges. So mediastinal disease, compression of the recurrent laryngeal nerve, an open airway and a problem voice. So the big C category is perhaps the least well thought of. The obvious group are our head and neck group, dependent on tumour location, tongue, lips, floor of mouth, base of tongue, soft palate, nasopharyngeal and larynx and parotid. It's maybe the disease itself that we're helping to support, but it may be the impact of chop, burn and poison. So surgery, radiation and chemotherapy. And it may be the impact, those things, the mucositis, the dehydration, weight loss, fibrosis, stenosis and xerostomia that we're working with. Some of the overlining principles of our work is to enable the patient to remain the director of their own journey and to facilitate the person with communication difficulty to maintain their personal relationships, and to ensure their inclusion in their end-of-life decision-making. It's our responsibility to support them by providing alternative, augmentative communication systems to assist the person to communicate as independently as possible in various environments and to reduce frustration and, more importantly, social isolation. During these COVID months, we've heard nationally but internationally of the significance of social isolation, and the world has been traumatized by that, but this is often a symptom that the communication impaired patient is facing on a regular basis. Symptom management of dysphagia to minimize aspiration risk and maximize the person's comfort, safety and pleasure at oral intake. And education to empower the person and their carers to cope with the distressing, rapidly changing communication and swallowing symptoms, and to address ethical and quality of life concerns for them. They will tackle communication difficulties. So communication, the ability to communicate one's needs, thoughts, feelings and wishes is central to a person's sense of self, of well-being and of quality of life. So looking at a few of the conditions that might be disrupted by their very nature, you can see that they scatter quite a range. I don't think we see a full 50% of brain tumours, but it would be good if you referrers are thinking, speech therapists might be helpful here. And I would say the same for lung cancer. Communication impairment is 100% impaired in dementia, 80% motor neuron disease, multiple systems atrophy, 90% in Parkinson's. So these horrendous neurodegenerative diseases don't leave communication intact. Communication strategies to support the person's inclusion in end-of-life decision-making and to maintain significant relationships. And often the person relocates during that health transition. So it might be at home, it might be rest home, self-contained units, it might be in the hospice. So the communication partners are really important, and education is an important part of the speech therapist's role to help the new listeners, help the speaker to maintain a fluency of relationship. Another important aspect of our work is the advocacy for health literate resources and things that are pitched at the appropriate level. We're working more now with young clients with dementia who have Down syndrome. So we need to make sure that if we're trying to keep them still driving their own ship, it's important to do things early, and it's important to do things in a very health literate way. A big shout out for TalkLink services, who are a national service, who provide alternative, augmentative communication systems. So Stephen Hawking made his very famous, but there are many different forms of communication device. Initially, Stephen used his to support his communication. So when he got tired, he'd refer to his machine. As his disease progressed, his disease was all-consuming of his capacity to speak, and the machine became everything for him. So augmentative communication is just what it says. It doesn't have to be a replacement. It can be supported by the person's other remaining skills. One of the other talents of the speech and language therapist is trying to match provision to need, because these diseases are diseases of change. Provision of voice amplification or hearing aids for partners. We might be involved with speaking valves and their care for patients with laryngectomy. In your area, your therapist may be the one that changes the speaking valves, tiny piece of plastic stuck inside the stoma that shunts the air through into the oral cavity, and the person will sound a little bit like themselves. It's their own air they're using to speak with. Or patients with trachees who might be using orator speaking valves or passimurus. Precious slide for me. This is Kevin. He has been a delegate for education for New Zealand. He has motor neuron disease. He could only move his head and was bedbound for 3 years. You see him here with a right mouse on his forehead, a bindi mouse, and he has a jelly bean foot switch. He also has a toe movement that allows him right-click for alarm. These communication devices allowed Kevin to parent 3 children, to talk of his needs for advanced care planning, to have long and lengthy discussions with the chaplain about spiritual matters, to chat and direct his health workers, to text his wife in the paddocks. He's provided training videos for New Zealand Speech and Language Therapy Association, and he engaged, really importantly, in intergalactic warfare, fast, competitive, and free to move from his disability, where his disability was invisible. So the devices here for communication enabled enormous quality of life and meaningful engagement. I'd like to acknowledge TalkLink, who were the winners of the David Oliver Beacon Award for Excellence in 2018 for their work to motor neuron disease. More things speech therapists might do. Dysarthria, slurry speech, so we might do some work to try and maximize awareness and precision in the early stages. Optimize context, simple things like moving the chair to face the listener, making sure it's quiet, cutting down the music, turning off the telly, turning off the vacuum cleaner before you ask the question. It might be low-tech, like spell charts, yes or no. Partner-assisted scanning is the use of the middle communication board where the therapist or the listener uses the finger as the cursor and moves across the rows or columns, and the person can blink to indicate where they want you to stop at the selected letter. High-tech, we've dabbled with a little bit. Light writers, text, Skype, iPads with apps, predictable. Eye gaze, trackballs, bindi mice, jelly bean switches, pillow switches. It's a funny thing to think that your toe might become your new communication device. These are enormous adjustments our patients have to make. Call bells and alarms, or Big Macs with pre-recorded messages. Total communication would also include face, gesture, pointing, and mime. I've put 2 other communication charts in here, really easy ones. The Bristol stool chart, a pictorial one. Your patient who can't talk could indicate either which number of bowel motion they wanted to refer to or could point to it, making communication easy, quick, effective, low embarrassment, and really important for those patients for whom they're going to have constipation challenges, which is many of our patients. The middle one is the pain score, also really effective communication strategy for you, the health professional, trying to weigh up whether the medication's right, whether you should begin a session because the patient's comfortable or not going to be able to concentrate because of their discomfort. So that's a wee bit about communication. Moving on to slide 11, let's talk about dysphagia. Dysphagia describes eating and drinking disorders which may occur in the oral, pharyngeal, or esophageal phases of deglutition. You can see on the pictures here a bolus in the middle of the mouth and heading backwards. What we're wanting it to do is to go into the esophagus. What we're not wanting it to do is to go into the airway. So a lot of our work is about education. The speech and language therapists minimizing the impact of dysphagia. So its possible consequences are choking, which is distressing for listeners, for public eating, and for the patient. Aspiration, which may become a chest infection and pneumonia. Dehydration, which will become poor concentration, halitosis, constipation. Malnutrition, which will become pressure sores, and ultimately death. So the speech here hopes to optimize function, improve comfort and eating satisfaction, and promote a positive feeling environment for the person and the family. With my motor neuron disease patients, I always talk to the cook at the beginning of the trajectory of the disease and say that you are unlikely to manage to be able to cater to the end of this condition. It won't matter how wonderful a cook you are, your cordon bleu skills will not allow the person to swallow by the nature of their disease. So you set the expectation so that when that occurs, the wife, if often the wife, but not always of course, but the cook doesn't feel that they failed their loved one. So setting that positive environment is really important. Choice and control in decision for eating and drinking. We get to be an integral part of that with our dietitian and doctor colleagues. It may well be that people choose to eat with known risk. The focus of our intervention is to minimize this risk and maximize comfort and enhance quality of life for the person on this journey. And it may be that we're doing this at the beginning of the palliative journey. It may be in the last hours of life, somebody is still wanting that piece of chocolate, that sip of whiskey. So we're hoping that we manage the trajectory of eating all the way through. Slide 13 takes a blink at some of the incidences across the different disorders. And you can see there's a high prevalence of dysphagia. We won't see these all of these patients because it's referrer dependent. But if you are a potential referrer to your speech therapist in your area, have a think about COPD or stroke or advanced malignancy and lung cancer as being reasons you might also include the speech therapist. Slide 14 tells us what the speech therapist is likely to do. A bedside or chair assessment and a cranial nerve evaluation, possibly food and fluid trials. Observation may be our biggest tool, and it may be that we use standardized assessments, but it may be that a really good history take and a really astute observation of the person performing the eating act and the drinking act where they are is actually what informs our wisdom. Sometimes we use the E10 score, sometimes the referrer does. Pulse oximetry gives us an idea whether the person's O2 sats are impacted by that swallowing phase. A drop of 5% of O2 sats is suggestive of silent aspiration. Obviously, if a person coughs and chokes, we know they've aspirated, but the silent aspirators are the biggest risk to us because it's an invisible symptom. Cervical auscultation, very, very useful in listening to the tubes, essentially, and whether they're compromised, whether there's a premature spillage, whether there's residual above the vocal cords, whether a cough to clear, cough swallow, safe swallow strategies will protect the airway, or whether they won't. For our palliative patients, sometimes we use feeds to make an analysis and to guide decision-making, and sometimes we use video fluoroscopy. While those tools are the A grade of evaluation, if the person is going to continue to decide to risk feed, there would be no point in dragging them into hospital, exposing them to video fluoroscopy analysis and assessment to say what we heard at your bedside is what we can see here, and your choice is still to eat, go for your life. So that's those tools may or may not be used for your palliative patient. But just a thought. They do sometimes help us guide patients in decisions over having a PEG. And more recently, a lot of the work coming out of the Rose Centre under Dr. Maggie Lee Huckabee's tutelage is the possibility of doing rehab in palliation. So there may well be a case if that's the route your patient is wishing to take and is wise to take, then rehab might be an option, and then instrumental assessment will be more significant. So slide 15 tells us what we're going to do about it. Rehabilitation and compensation are our two main tools. So compensation might be positioning. It might be upright, but you might be dodging pressure sores on a very slim bottom. So it might not be upright. It might be that you need to have the patient slightly supine because the pressure of their stomach on their diaphragm competes and they can't breathe. And you need to open their airway as much as possible. And as they then come to swallow, you endorse a chin tuck posture. So understanding how compensation might be helpful is really important. Speech therapists are known for their dysphagic cups. These are sort of backless cups with a slope. I always demonstrate it with my big nose and say your big nose gets in the way when you drink. It means you tip your head back, opening your airway, and food and fluid is then a risk to you. Chin tuck with this special cup will stop you doing it. You swallow with a tipping wrist. You don't swallow with a tipping head. Respiratory management, timing on breathing is really important. Small sips. The maroon spoons are tough plastic made for that purpose. They're very broad and shallow. So somebody with lip cancer will still be able to get something across their mouth without the pain of trying to get into a metal spoon. Somebody with dementia who might bite on a metal spoon or might trash a thin plastic spoon won't be able to do that on a maroon spoon. So your speech therapist can help you with that. Enteral feeding might be augmentative support nutrition as well. Rehab might be useful for your lymphedema patients where swelling impacts on their swallowing. Orientation of the muscles, performance and awareness of this, they help you control and learn different rehab strategies, Shaker Masako maneuvers, building strength and airway protection. Gradual descent in disease means that some of these things may swap hands as in their time may come and pass. So your speechy who's aware of disease trajectory will know what's the best strategy at the best time, because of course it will change. So page 16, just a quick summary there. Food and liquid consistency modifications. The INSEE is the international standard for that now, and I'm sure your local speechies will be happy to talk to you about that. So consistencies might be soft and bite-sized or regular, moist mints. Fluid might be slightly thickened or moderately thickened. Thickening fluid is not the solution to every swallowing problem, and it may actually significantly exacerbate dysphagia in a COPD patient or a patient with lung cancer. So the right thing for the right person at the right time is really important. The eating with known risk. Most DHBs have pamphlets now which help guide families and patients with this. Sometimes it causes domestic or family conflict. The wife might want the husband to live forever. The husband might say, thin whiskey is the way to go, and I don't care if it goes the wrong way, and if I get a chest infection, so be it, that's fine. So as patients have got a stronger place in their own decision making, this is a New Zealand context, and our patients have every right, as long as they have identified capacity. Globally, that's not quite the way. So I'm very aware of patients that come from overseas who expect to be told what to do, and our New Zealand context is not that way around. The patient drives their own ship. Management of oropharyngeal secretions is really important. It's a classic characteristic of end of life, and your doc team may be trying to manage that. But speech therapists may be doing other things to try and prevent oropharyngeal secretions being an issue. Sometimes it's because of their viscosity, too thin, too much. Sometimes it's because too thick, immovable, and sometimes it's because they have no secretions at all post-radiotherapy and they're as dry as hell. Oral medication may become a challenge as the disease progresses, so the speechy will work in conjunction with your medical, pharmacy and dietitian team. Oral hygiene I'm going to talk to you about a wee bit's time. It's so important, and the research suggests that dependency on others to be fed and dependency on others for oral hygiene makes you more vulnerable for pneumonia than does dysphagia. So there's a giant place. I should have just talked about oral hygiene this talk, really. As end-of-life approaches encourage the use of oral hygiene in lieu of feeding and for psychological and psychosocial wellness. Another thing that might be useful in terms of therapy would be the use of a TheraBite for trismus, so jaw clamping. Radiation sometimes is used for that. My experience is to try and whack out the parotid glands. You can create trismus and then you have your own problem to resolve with that. But the head and neck crew sometimes are using TheraBites to keep their mouth opening. This is really important if you want good oral hygiene as well as food and fluid access. So close to my heart, slide 18, is oral care tips and tricks. I want you to remember this ballerina mouse for the twirl that she performs while holding her mouth swab. The strategy that we would encourage people to do would be to dip into your mouth washes. Savacolin research has a better rating than Listerine, which is still good. Sometimes people like bicarbonate of soda. Sometimes people like salt and water. So dip, squeeze out the excess, wipe around the oral cavity, doing the cheeks, the roof of the mouth, the tongue inside the gum boundary, outside the gum boundary, and then throw it in the bin. In a hospital context, it's a one use. Sometimes at home, that's not the way it is. The twirling motion of the swab is really important for two reasons. One, to catch the secretions and bind them around the swab, but also for debriding a surface that's then going to be coated in bacteria. Bacteria in secretions that head on south into the airway are your chest infection and your pneumonia. So brilliant oral hygiene will stop that. It will also help with mouth freshness. Ladies go to hairdressers and feel fabulous when they've had their hair cut. And oral hygiene is the same. You feel so much fresher with a sweet-smelling mouth and knowing that it's clean. Your bacteria light mouth is really good. Increasing the fluid in the summertime for pegs increases hydration and helps the patient have mobile secretions. Antimucolytics like pineapple juice and dark grape juice are really helpful to break that thick, tenacious mucus. Saline nebulas also useful, but people may just not want something on their mouths and their faces. A cough assist machine is a real asset for our motor neurone disease patients to help clear those rattling secretions that stick in the airway. Sore lips might benefit from lip balm, and soft collars will keep a jaw closed and reduce mouth breathing and stop that dry secretions. Mouth cares are really important for people who are nil by mouth or peg dependent. We think that because food isn't going into them, the mouth doesn't need that attention, but of course it does. Mouths in patients who've had surgery or motor neuron disease may have a withered and shrunken tongue that can't debride itself against the roof of the mouth. So they are dependent on you, the carers, to provide that scraping and debriding activity off the roof of the mouth. Bite blocks may be important for propping the jaw open so that the helper can get a good light in and a good torch in. So please remember the twirling mouth. Twirling is really important, not scrubbing up and down with a swab. As your world shrinks, the little things become the more important. Slide 19, we touched on thick, ropey secretions. So behaviour modification, sometimes it's just enough to say suck, swallow, or also I say cough, swallow. Patients are good at coughing and bring the secretions up, but if it's not followed by a swallow, it won't go into the stomach. It'll drop back into the airway. So very simple behaviour modification strategies can make big difference. Rolled towels as good props are important. Tip and tilt chairs, fantastic. Hospital beds may give you a much better angle for eating and feeding. The salt or headmaster collars may be useful. The salt collar is spring-loaded and interactive. So if you need to lean your chin forward for a chin-tuck posture to protect your airway, the salt collar will allow this, but still give you some upward movement. There are some patients in New Zealand who like to manage their excessive secretions by tinctures of horseradish or goldenrod, but there's also more structured medication. Atropine eye drops last a little while, so if you had to go to an appointment, you might use that. Amitriptyline might be useful and might be also something that the patient is having for their depression. Hyacinth patch is great for non-oral patient, Buscopan. I have had some experience recently with people having sort of psychotic psychosis type events with a hyacinth, so it won't be for everybody. Guy coprolate, also useful. Obviously, all these medications are doctor initiated or supported, or your speech therapist might just ask you for them. Radiation, mouth moisturizers, GC gel and water bottles, good for secretion management. And Botox now has become a bit more common practice for patients. We tend to use medication at the beginning of a 3-month period. Then we use the Botox. It takes sometimes 8 to 10 days to kick in. We stop the medication. The Botox lasts for the 3 months approximately, and as it begins to fail in its function of stopping the excess saliva flow, we begin medication again and book in the next appointment. In the past, I've been party to laryngectomy and trachea for surgical management of excessive saliva. For our patients, it has worked particularly well, and they weren't trading anything, already having lost their swallow and their speech. Buscopan doesn't cross the blood-brain barrier, so sometimes it is the preferred product of use. So 2 things that speeches are well known for, communication and dysphagia. Just nipping in on slide 20 to unintentional weight loss. So anorexia or cachexia syndrome, a complex metabolic process found in many end-stage illnesses. So loss of or absence of appetite with weight loss, that may be part of the chapter in the person's life beginning to close. And I think honouring and hearing that and not worrying about it is very helpful and supportive to the cook, who is an integral part of the package of trying to support their loved one. Muscle wasting also very important, and we mentioned earlier, just to say I want this patient to be seated up on a chair if they have a very friable tissue and pressure areas may not be a possibility. So understanding muscle wasting and its impact on pain and swallowing might be really important. Anxiety and distress has a really big impact on weight loss, and we'll talk about that shortly. So on slide 21, your speech and language therapist can help minimize unintentional weight loss. So this might be by consistency modification, so making it easier and taking some of that pressure off. So yes, you can battle your way through anchovies on a pizza, but you may find that shepherd's pie is much easier and it doesn't take so long, and you eat it because you can get to the end of the meal because you're not exhausted. So again, behavior modifications. Thickened drinks might be helpful. The Pure Food Company have pea protein powder added to their protein purees, which is a fantastic way of getting high calorie, small volume. Talking about communication strategies during meal times to promote oral intake, so no talking and eating, will keep the person safer. And good advanced care planning may include discussions on PEG or RIG or not, and this may help manage the weight loss challenges. There's some interesting research coming out to suggest that patients with motor neurone disease who are slightly obese at the beginning of their diagnosis actually do slightly better. So there is great value in that weight, a little bit of weight gain at the beginning. Moving on to breathlessness, slide 22. Breathlessness is a complex experience of the mind and the body. It's not a one-dimensional event. So pulmonary is important, cardiovascular weakness, anxiety resulting in hyperventilation, pain and neurological condition all bring with them breathlessness. Slide 23. So what can we do to help minimize that as speech therapists? Pacing and frequent breaks for breath top-ups. So it might be that the food is reheated 4 or 5 times with a microwave because it's taken so long, but it's been managed by good breathing in between times. The modification of food and fluid consistency to minimize aspiration risk. So if you over-thicken fluids in a COPD lung cancer patient, the epiglottis, as it closes over to protect the airway, will be over for a longer period, and that breathlessness will feel much more compromised. So getting the right stuff is really important. Mash and chop on the plate may save chew time. So using your knife and fork as your teeth may be really helpful. Little and often, so 5 meals a day, so something like morning tea and afternoon tea with food, or delaying a dessert for half an hour and making it come later. The use of sip feeds, so the person knows, if I've only had 40 sips a day, I've had enough. So if I can manage my way through that, I don't actually have to plough through food as well. The nasal prongs may also be running alongside your patient. The picture of the dinosaur there is that vegetarian dinosaurs, had to graze for 24 hours of a 24-hour day. And I often tell my patients, think dinosaur, just graze. Page 24, anxiety. The feeling of worry or nervousness or unease about something with an uncertain outcome. Your patients with motor neuron disease will voice this throughout their disease trajectory, and honouring that at the beginning with an early fear, perhaps from the carers, and honouring it in their closing hours will be really important to know how you're managing those symptoms. So on page 25, let's think about what the speech therapist might offer your team. To help manage the person's anxiety, the pictures there are of celery soup. So somebody who's at risk of choking but really fancies a piece of celery, you might get their celery, crunchy pieces, converted into celery soup. It's still honouring their quality of life choice, but you've minimised the risk. It's much less likely to stick in an airway. You're helping the patient balance choice with risk. So if there is no cough to clear, and the person does want to dodge dying of an airway obstruction, you would notify them that peanuts are not a good choice, but almond essence in their smoothies might be a good way to get a nut flavouring in. Empowerment, education and support of carers is really important in risk feeding, and documentation as well, particularly if you're in an institution where the person who has made a choice to eat with a known risk, something that could block their airway, but the dependent feeder, is an employee, it makes them very stressed. So making sure that the documentation is tight around this, and the carers feel that they are supported by their management in supporting their patient. Timely advanced care planning is really important. I always think of our advanced care planning as a dry run. How do you want it to look? So your speech therapist is well equipped to help the patient with communication impairment, or the patient who's going to have to make decisions about eating and drinking. Advanced care planning is right up your speech therapist street, and will help them. They will help your patient walk through a dry run of how that closing aspect of their life might look. ACC support might be needed for that. AAC, sorry. So to make sure that the end-of-life decisions are still being honoured. So at the beginning, the person may be able to speak their advanced care plan. In the middle, they may use predictable with an iPad. At the end of their life, they may make their decisions, I don't want any more food or fluid through my peg, and it may be done by a look left for yes. So do you want food through your peg? Look left for yes. So that may be a very light form of communication support. Also using language that normalizes dying. Page 26. Psychological and emotional support. The gift of support that we offer can be one of the most appreciated, yet one of the most neglected of our skills in primary care. And I was really excited when I did my course in Auckland to hear about the value of therapeutic self, that what we as clinicians and all of you in your different rooms across New Zealand bring to your patient is the value of your therapeutic self. And it's a particularly useful resource you bring to psychosocial wellness and emotional support. So on page 27 or slide 27, early emotional support, your advanced care plan, your allied health professional may be one of the people who's first on the scene. We help to improve mood and aid quality of life, help cope with the demands of non-curative disease, attend to emotional adjustments. Motor neuron disease is a great example of the fact that you are much better yesterday than you are today, and that is their every waking day. Every day they are better yesterday than they were today. So how much adjustment does that need? We're able to help link to other services when questions may move outside our scope of practice. That may be chaplaincy, or it may be field workers, or it may be support groups. Page 28, Tafari Tapafara in laryngectomy. Alan has been amazing and put himself forward to talk to the New Zealand speech and language therapists and provide training videos for us. So Alan is a palliative laryngectomy and has given us amazing, fabulous information. And he said to me one day, the greatest thing you can do for me is to know me. So I think communication, a skill that the speech therapists are trained in, puts us really in a good place to make sure that that's what we do. So I've used the Tafari Tapafara model just to think about Alan's management of his palliative laryngectomy. So body, we would manage his stoma hygiene and appearance, humidification and valve cleaning and valve changing. His spirit, talking about what brings him meaning, communication, how can he participate in church, how can he participate on the marae, and if he doesn't want to go on the marae because of his communication challenge, how do we support and understand that? Mentally, his risk of isolation, and that finding, who am I? Ko waio, what is my role in life now? And whānau, how can I manage my mokopuna when they won't listen to me? How can I be with my whānau when I can no longer feel able to go onto the marae? Other things that speech therapists might bring to your team would be conversations around sentinel bleeds for our patients, or catastrophic bleeds, planning with things like call bells and alarms, things like red towels or brown towels in the house, medication in the fridge, things to make sure that our laryngectomy or tracheostomy patient is supported through that end of life journey. Last section, section 7, minimising impact of fatigue. So looking for alert periods of oral intake, choosing the best time for the main meal, which may be a big shift for some people. It also may be that the patient is sleeping for giant times of the day and there aren't 3 meal times a day. So helping the family adjust to the fact that we're not after whole meals or every bit of fluid that the person should have. We're after what's best and what can be managed. Small volume, high calorie, pure food company, fantastic, have a Google. Pacing through the mealtime, conserving energy for anticipated speaking situations. So it may be that the family put a big note on the outside of the door which says 15 minutes only, so that the patient is not exhausted and has time for everybody they wish to talk with. Use of a voice amplifier may be really helpful as well. And we've talked about alternative, augmentative communication being used if fatigue is impacting intelligibility. And also if the listener just nudges things like, show me, write it for me, can you gesture it? Here's a spell chart, can you spell me the first words? Little things that come from the listener to nudge. Page 30, end-of-life cares. Call bells, hand squeezes, blinks and light ACC. As I said, one of my MND patients when I first came to New Zealand taught me the technique, look left for yes. It kept her driving all her decision making. Everything was done by yes, no questions, and look left was her one movement. Touch and eye contact, goes without saying, is really important, and saying what you need when you need. Steering your ship, as we mentioned earlier, no more 40 sip through my peg. Great mouth cares, sweet smelling to kiss. I think that's really important, and it's really tender, the opportunity to do mouth cares for your loved one, and then they will smell fresh. If the grandchild wants to kiss Grandpa, that's what he's going to remember. Grandpa smelt minty fresh when I came to see him at the hospice. No dry plaques under non-invasive ventilation masks, no broken skin on the bridge of my nose. There's an app called Record Me Now, where you can leave messages, spoken messages, when your speech is good. So Record Me Now might be something that you draw your patients' attentions to. Slide 31. He waka eke noa. For the purpose of showcasing how your speech therapist could be of use, I've tried to highlight their focus, but of course they are at their best when they're a member of a team. And of course, in this beautiful waka, you can clearly see the dietitian, the OT, the speech therapist, the social worker, the doctor, the allied healthcare worker, the support person, and the field workers, all in the waka together. Slide 32. I hope that I have thrown early morning light on the work of speech therapists with people and families who have palliative care needs. I would encourage you to make contact with your local speech and language therapist. And if they're in the room, I'd like them to wave right now, smile and wave, so that they can be identified by your group. If not, something we've all learnt about is Zooming. So if your speech therapist is not here, please Zoom into her, find her or him, and can get them to consult with you so they can be part of your team. Of course, Zooming, they could be in the Outer Hebrides. They don't have to be local. So phone a friend and get them to support you. Patients are like snowflakes. Beautiful, precious, unique,